Arthritis Foundation is a patients organization in the US, and this is they kind of help patients to understand what the arthritis is, and they hold meetings and they hold educational seminars, etc., etc. And they depend generally on the pharmaceutical industry as well as people to become members. And since 2003, I have done this talk for Arthritis Foundation in Portland. So I trained in BJ Medical College and KM Hospital, and then I was in England, where I did my rheumatology training initially, and then I went to US. So since I was in UK, I had close proximity to EULAR and Europeans, etc., etc. So not many people from the US go to the EULAR meeting. Generally, Americans go to the American College of Rheumatology, not to EULAR. I go there, and so when I go back, I sort of teach or talk to my rheumatology colleagues in Portland, what did I learn in EULAR? That's how it started. And the Arthritis Foundation organizes a dinner just like this. I give a talk exactly like this, and then the companies pay Arthritis Foundation. So this is one of their fundraising activities. So I did this talk for them, which I've done since 2003 for the last 21 years. This year I did the talk also in Seattle. So one of the things I will show you is also my travel. So this is, and I'll show you some of these pictures, but you guys can see these slides, right? Those who are on the, can you say yes, somebody?
Yes, sir.
Yeah, thank you. And you can see my pointer. You can see my pointer. Anyway, the picture on the very top left is, this is the museum in Vienna. This year the EULAR meeting was in Vienna, Austria. Ajit is somewhere, right? Oh, yes, I met Ajit there. So he was there. I saw him in the meeting actually. So this is in Vienna, and then these are some of the pictures which I will show you during my talk. So these are my disclosures, and the opinions expressed in this presentation are mine only. Abstracts are chosen, slides prepared by me with no influence from anybody else. So I'm only going to talk about 20 abstracts. I mean, there are thousands of abstracts presented there. This year, the meeting was 18,000 people. It's unbelievable size. This meeting has become beyond American College of Rheumatology, 18,000 people. And Ajit can tell you how many people were just wandering around and huge conference hall. So I'm going to talk about Sjogren's syndrome, systemic sclerosis, lupus, vasculitis, rheumatoid arthritis, XLSPA, PSA, CAR T therapy, and guidelines or recommendations. And I generally will go about quality rather than quantity. I'll give you some background information on some of these things. And this will take 1 hour, so I don't know whether it's too long or too late. And things are of practical importance may influence or change practice. And again, these are my personal opinions, what is important, what is not opinion. You may or may not find that to be useful. So we're going to cover 20. So in 1 hour, you will know the answers to these and few more questions. So what's the mode of action of nipocalimab? What is a drug of choice in severe vascular or CNS Behçet syndrome? How good or how bad is the reproducibility of minor salivary gland biopsy reading? Do you guys do minor salivary gland biopsy for Sjogren's or not much? You do that, yeah. What is new in the EULAR treatment recommendations for systemic sclerosis? What is daratumumab being tried? Which drug has been, which disease it has been tried for? And how does daratumumab work? What is the shortest glucocorticoid course with tocilizumab one can use to treat giant cell arteritis? What is the difference between a nanobody and an antibody? This probably everybody would know. Which biologics are touted to prevent incident psoriatic arthritis or new psoriatic arthritis in patients with psoriasis? Should levels of rheumatoid factor impact our decision? No, this is not going to work. Should levels of rheumatoid factor impact our choice or biologics to treat rheumatoid arthritis? And how can we optimize referrals of inflammatory disease to rheumatology clinics? So these are some of the questions. If you already know the answers, then you're wasting your time here. And you might as well go and just eat and go home. If you don't know, then you can stay around. So if you stick around, you'll see pictures of Austrian Alps where we visited. So, okay, good. You're not seeing this because I'm seeing something else here. So where is Austria? So Austria is, this is Austria. This is Need to move this thing from here. Okay. So Austria, so that's Austria that you're seeing. So Austria is part of Western Europe, but it is the easternmost part of Western Europe. Everything on the east of that, and I know Sanath has visited that, but there is Hungary and Slovakia and Serbia and etc. So all those Eastern European countries are attached to that, but Austria is considered part of Western Europe. How many people here have visited Austria? Of course, I know Ajit has visited. Many people have visited in the front row. Very good. So you guys know where Austria is. So it's a landlocked country in Central Europe, lying in the Eastern Alps, known for its classical music and Baroque architecture, coffee culture, winter sports, alpine traditions. Its capital is Vienna, is the most populous city. And so the center of this Habsburg monarchy, and they're very proud of Habsburg monarchy. It's like if you go to Maharashtra, everybody is proud of Shivaji Maharaj and Maratha Empire, right? This is like their Shivaji Maharaj and Maratha Empire, like the Habsburgs, are people are sort of still thinking about Habsburg. So they championed Roman Catholicism. And if you go to the restaurant or for dinner, there's going to be dinner schnitzel, wine. That schnitzel is basically pork, which is flattened pork. And there is a Vienna sausage, Wiener schnitzel, and Vienna sausage. And there are some of the pictures of it's a very pretty country. It's in the Alps. So what you're seeing on the left-hand side at the bottom is how it looks in summer and then in winter. So this was my third trip to Vienna, to Austria. And so my wife came with me, and then so Vienna is here. We landed in Vienna and we rented a car. And then we drove along this Autobahn where there is no speed limit. This is next to Germany, so there is no speed limit there. And then we went through Germany down to this particular spot here. And this is called Grossglockner. Grossglockner is the tallest peak. This is 3,798, 3,800 meters, so about 14,500 feet. And this is a national park. So I'll show you some of the pictures of these later. All right. So I'm going to ask you some questions. So I hope this thing works. Audience response system. And I think we decided that they will be able to take. So those who are actually on at home, they might be able to do this, right? So this is, you need to text. So 22333. So take out your phones, everybody here also. And let's try to see whether it works. It's not going to work. QR code will work. All right, but those at home, it will work then? Yeah. Why would it work at home and not here then? Oh, the QR code will work from home. Oh, I see. Okay, then hang on for a second. Then I need to stop sharing this, right? No, it's not on the next slide. It's on the different screen altogether. So I need to now stop sharing.
Stop share.
And now I need to share. Now I
Go to Chrome. We'll just check it's there.
Okay.
So we can go back.
So now go back to share. So I need to go back to Zoom. Shared screen.
This one.
Yes. So can you guys see this from home? Somebody say yes or no. Say something. Can you guys see this or no?
Yes, sir.
Hello? Can you see the QR code?
Yes, sir.
Present slide.
Present.
It will show all the options now.
I know, but then I need to go back because they may not have gone on this. This is leave meeting. No. How can we get rid of this? Huh?
This is okay.
Leave meeting.
No, it's being recorded. That's fine.
So let me take this down. So
he assess this
can you guys see this
yes.
screen? Oh yeah. Like alakade. Oh, okay. It's coming. Okay. So then in that case, this is the best thing. Type. So Atul Deodhar 391, and you have to send that text to 22333. Yeah, or you can join by web. Very good. And so I need to make this. You guys are already working. Amazing. So the mode of action of escalimab is, and this is used in Sjogren syndrome. So see more. Oh, actually, hang on. There are more options here. Okay, there are 4 options. Mode of action of escalimab used in Sjogren syndrome is kills B cells, kills plasma cells, blocks co-stimulation of T cells, or it is IL-13 inhibition. Is everybody online? I'm pretty sure you guys are already on this. Are you guys on this? Yeah. Varsha? Who hasn't got it? QR code. Ajit, QR code screen कर दिखा वाला top corner. That you guys got it? Otherwise, somebody can agitate me. If you scan that thing on the very top, Alaga? Good. And I don't know whether people at home are voting. Did you guys vote from home?
Yes, sir.
Yeah, very good. Thank you. All right. I'm going to wait for 5 seconds. So kills B cells, kills plasma cells, block co-stimulation, and IL-13 inhibition. So IL-13 inhibition got 43% of votes. 29% thought kills B cells, more 33%. Nobody thinks it kills plasma cells, and blocks co-stimulation is 27%. All right, very good. So now, how do we go to next one? Okay, next. Now this one I need to activate. This is not active. So what but I don't know whether this is going to show up here. You might be voting, but it's not going to show because I need to activate this. So एक second, let me activate once I activate, and then I need to go to the next one.
Next.
But every screen I have to activate. That's the thing. On this one, I don't know whether I
So
activate.
this is how it looks on my mobile.
I know, but then if you vote and see whether it comes up.
Ek
Oh,
yeah.
okay. All right. Okay, so this is also working. Which of the following statements are true about neonatal FC receptor? So the first choice is neonatal FC receptor is a new target for juvenile idiopathic arthritis. Number 2, neonatal FC receptor is present in adult life as well, and it is implicated. Can you guys see this, the full thing, which I'm not able to see? Come on, this thing? In IgG recycling. FC, the neonatal receptor can be expressed till age 25 and is important in axial spondyloarthritis. And neonatal FC receptor is internalized and breaks down anti-SSA and Rho antibodies in neonatal lupus. All right, you guys are getting it? So we'll wait for 5 to 10 seconds. So 12%, 13% think juvenile JIA, 65% said that it is implicated in IgG recycling, 6% said that it's present till age 25, and 21% think it is neonatal lupus related. All right, very good. Now let's go to the third one. And third one, I don't think I have activated yet. You can see that how effective was fecal microbiota, but I don't think you'll be able to vote. Are you voting? And nothing is coming up. Oh. How effective was fecal microbiota transplant in GI involvement in systemic sclerosis? It failed. It significantly improved stool consistency, diarrhea, fecal incontinence, etc. Numerically improved fecal soilage and diarrhea, but did not improve. And I can't read this myself, this question. Significantly improved UCLA scleroderma clinical trials consortium scores. 50% think it failed, 54%. 31% think that it numerically improved, 20% thought this, 7% think it is improved stool consistency. So there are all 4 things have gotten some votes this time, which is very good. All right, last question. In treat to target escalate trial in radiographic axial spondyloarthritis treated with increasing doses of secukinumab and adalimumab. Treat to target group had reduced radiographic progression compared to usual care. B, treat to target group had better ASAS-40 responses compared to standard of care, and treat to target was not superior to standard of care. This one has only 3 choices. You guys can see this as well on your screens. Yeah. All right. 27%, 13%, 56, 53%. Very good, very good. You guys are very, very good. All right. Don't think there's anything. That's it. We have got 4. I'm going to exit. And I'm going to stop screen sharing, stop share. And now I need to go back to share again and then go to the slideshow. All right, very good. Thanks. This works. So we did this question, this question, this question, this question we did. All right, so Sjogren's disease is what I'm going to speak about first. So being very interested in axial spondyloarthritis, I wasn't really looking at Sjogren's syndrome. For many who might be interested in Sjogren's disease. So before I go to the trials, I just want to quickly tell you about the outcome measures. We know about ACR20, ACR50, etc. In Sjogren's syndrome, there are these 3 important ones, outcome measures. EULAR Sjogren's syndrome patient-reported index. This is called ESPRI. This is very important from the patient's point of view. There are 3 things patients complain about in Sjogren's: pain, fatigue, and dryness, sicca. And so on a 0 to 10 scale, how much is your pain on a 0 to 10 scale? How much is your fatigue on a 0 to 10 scale? And how much dryness do you have 0 to 10 scale? So it's as simple as that. Those are the 3 cardinal symptoms of Sjogren's. And so that goes from, the score goes from 0 to 10, so 30 score, etc. And this is the most important from the patient's point of view. Then there is this SDI, which is the EULAR Sjogren's syndrome disease activity index. This has got 12 domains and 44 items, and this is pretty complicated. And this is not what patient is looking for, but this is what doctors are looking for. This is like, we are more interested in CRP, patient is more interested in pain, in rheumatoid arthritis, similar situation. And clinical SDI, they actually remove some of these complicated things which are there in this SDI, and that actually becomes slightly, 40 items rather than 44 items, but it is still pretty complicated. So remember that from patient's point of view, ESPRI is important. From doctor's point of view, SDI is important. So escalimab in Sjogren's disease, this was a phase 2 48-week randomized controlled trial called TWINS. So what you're seeing here is a B cell, and this B cell has got all these various molecules expressed on the cell surface, and the molecule expressed on the cell surface, CD20, is the most common that we know about. And these are all the rituximab and ocrelizumab. These are the drugs that block that. There is BCMA. And there's BAFF and APRIL are the cytokines which make the B cell active. So here is CD20, and escalimab is basically an FC silenced anti-CD20 monoclonal antibody. So CD20 and CD40 ligand, this it is important for co-stimulation of T cells. So there was a question, how does escalimab work? Escalimab actually blocks the co-stimulation of the T cell. And many years ago, 2 decades ago, there was this anti-CD20, anti-CD40 monoclonal antibody was developed to treat lupus. And patients develop pulmonary embolism and deep vein thrombosis and etc. because platelets express FC and FC receptor. And so this particular monoclonal antibody somehow with the FC receptor would sit on the platelets and cause platelet clumps. And there were all kinds of problems. So for many years, pharmaceutical industry stopped developing CD40 monoclonal antibody. These people silence the FC, so there is no connection with the platelets. The CD40 monoclonal, the ligand is also called CD154. So all these patients who participated in their anti-Rho SSA antibody positive, and there were 2 cohorts, large study, even though it was phase 2 study. 173 people had high disease activity, so they had high SDI, and 100 patients had high ESPRI, which is what the patients like. And these were the 150, 300, 600 milligrams of subcutaneous dose every 4 weeks. And in fact, the week 24 data was presented at the ACR meeting last year in San Diego. Here at EULAR, they were presenting 48-week data. So this, what I'm showing you, is what was presented in ACR. And the drug worked. It was statistically significantly better than placebo. Here they were showing what happens then after week 24, the placebo patients move on to receive the active drug. And what caught my eye, so this is called a forest plot. And these are ESPRI scores. And what you're seeing there, ESPRI, there, it is very difficult generally to treat Sjogren's syndrome patient and their aches and pains and their fatigue. And we generally poo-poo them as, oh, this is fibromyalgia. Can't do anything about it, just get out of here. And so here, the FACIT F score, as you can see, dramatically improvement in this. So everything on this side is improvement, showing improvement. So their fatigue score improved, their SP score improved, and the original graph that I showed you, the line graph, that was the SDI. So improvement in disease activity and patient-reported outcomes. But there were these significant serious adverse event in 11.4%, 14.3, 11.2. Two people died, one with PJP pneumonia and one with congestive heart failure. So this is not a simple drug. This blocks this interaction and can be pretty serious. Next is nipocalimab. Nipocalimab, this study is the Dahlias, and most of you got this mechanism of action correct. So nipocalimab is a monoclonal antibody against the neonatal FC receptor. Neonatal FC receptor, all of us have it, even at this age, even though we are non-neonatal. Transmembrane protein present throughout the life, shown here in this blue, and this is the nipocalimab. It's located mostly inside the vesicle in endothelial and immune cells, and it reduces the clearance of IgG binding and recycling. So it keeps the IgG going rather than breaking it down. So if you block this, then you're going to let the IgG break down and disappear. So it basically gets rid of antibodies, and usually the autoantibodies, not the good antibodies. That's at least the theory. So nipocalimab enhances breakdown of autoantibodies by blocking the IgG recycling pathway without broad immunosuppression. This is the important part. So it does not block IgA, IgF, IgM, IgD, and they claim that it doesn't. You've got tetanus antibodies, and you've got antibodies against COVID, and you've got antibodies against whatever, flu, because of your shots. Those antibodies are not broken down. Only autoantibodies are broken down. I don't know how that happens, but this is what the claim is, and we'll see. So this study called Dahlia, this was again phase 2 study. This was a late-breaking abstract oral presentation, which are generally very good abstracts, late-breaking abstracts. So to evaluate the safety efficacy of nipocalimab phase 2 randomized controlled trial, this patient had clinical SDI score. This is of more than 6. You remember that score was from 0 to 40. Clinical SDI, not ESPRI. These are seropositive patients for anti-Rho 52 antibody. This is given IV, 15 milligram per kilogram IV, led to improvement in clinical SDI and similar trends as shown here. Now, this is the ESPRI, and this is what is important from the patient's point of view. You cannot tell the patient, oh, your CRP is getting better. Who cares about your joint aches and pains for rheumatoid arthritis? Patient won't like that. So patient want their pain and the fatigue and etc. And this was pretty good till week 22. His drugs seemed to be improved, and then suddenly something happened between 22 and 24. And here it is not statistically significantly different. So the company said, shucks, it should have been. Anyhow, it's well tolerated, no new safety signals. So I said, no new safety signals. I mean, I don't even know what the safety signals are. So I looked at the safety signals table. So they don't have any MACE events, major adverse cardiovascular event, no infusion reactions, hardly any opportunistic infection. So it is true that this is a safe drug. It only gets rid of the autoantibodies, does not get rid of other antibodies. So infection is not that bad, etc., etc. So they are going from phase 2 to phase 3. There was criticism about the drug because ESPRI did not improve. You must get the patient to feel better. No point saying that your SDI is getting better. And it was getting better till week 22, and that was a statistical quirk. Reliability of salivary gland biopsy in Sjogren's disease. So this is from Belo Horizonte that I was telling someone about. This is a big city in Brazil. Their annual meeting is next week. A week from today, I'll be in Belo Horizonte. This is their Brazilian Rheumatology Congress. So they wanted to see if you give it to two different pathologists, the same biopsy, will they get the same results or not? Which I thought was very clever. And they were looking at intra and inter-observer reliability. So they had three pathologists. Two of them were specially trained by EULAR about how to read histopathology of salivary glands. And one was a regular histopathologist who was not specially trained for salivary gland. They would do breast biopsies and this and that, whatever. So they wanted to see how do the special training people work with each other and how do they compare to somebody who's not specially trained. The bottom line is the inter and intra-observer analysis showed very good agreement. Kappa value is more than 0.6. And that focal FS is the focal score, more than 50 lymphocytes under one high power field diagnosis. So the ICC, which is the intra-class coefficient, intra-class correlation coefficient, was 0.71 when compared to regular. So examiner A and examiner B are the specially trained, and examiner R is a regular pathologist. So when they compared the regular pathologist with specially trained, still very good. So I thought it was very interesting. So those were the three the Sjogren's disease abstracts I thought I will present to you. All right, whenever I show you a picture like this, that means I'm changing the topic. So this picture I have taken. So this letter is double S, SS. So this is Grossglockner. This looks like the letter beta, but this is in Germany, this is German language. So Grossglockner is the tallest peak, and this is the Grossglockner High Alpine Road. This is one of the most beautiful roads in the world that you have to drive your car on. This is of course not Autobahn. This one has got, this is 37 miles, which has got 27 hairpin bends as shown here. This is, I've taken this picture here. And it goes from 2,000 feet to 8,000 feet in elevation. And there are cyclists coming down and cyclists going up, and then there is this hairpin bend, and there is spectacular beauty as shown here. I drove there. And this is another picture, as you can see. And these are, I mean, spectacular mountains there, and you're kind of climbing up here and going there. There is a toll of 44 euros to get onto this. And the reason why it ends at 8,000 feet is there was this glacier which came down from Grossglockner and ended and actually went further down there. And you can see the global warming. So my wife and I, we went hiking there to the glacier, and now you really have to hike long distance to go to the glacier. And there are these signs that in 1975 the glacier was here. Then you walk another kilometer. 1985, 1995, 2005, 2015. It is really sad. What you see is how the global warming is affecting it. These are some of the other pictures I have taken. It is absolutely phenomenal, spectacular. This was the first week of June that we were there, or second week of June. All right, systemic sclerosis and systemic lupus erythematosus. 2024 update of EULAR. They divided systemic sclerosis like Grappa divides into psoriatic arthritis domains. So there are 8 domains of systemic sclerosis: Raynaud's phenomenon, digital ulcer, pulmonary arterial hypertension, skin fibrosis, interstitial lung disease, musculoskeletal, gastrointestinal, and renal crisis. So that's 8. And I didn't really find anything dramatically new here. So they actually had their last update was in 2017. And I couldn't find anything really new. So Raynaud's phenomenon, this is calcium channel blocker. This is the PDE5 inhibitor, phosphodiesterase type 5 inhibitor. Iloprost, of course, in serious situation. Digital ulcer, the same thing. Phosphodiesterase 5 inhibitor and iloprost, and etc. And then pulmonary artery hypertension in the US, we rheumatologists don't treat. We generally give it to the pulmonologist. However, the interstitial lung disease we treat. Is that the same thing here? No? Yes? No? The other way around. So you treat pulmonary hypertension and you give the ILD to the pulmonologist. ILD also you give. So you don't take care of lungs at all. You co-manage. Yeah, fair enough. Yeah, fair enough. I mean, and we have a combined clinic on a Friday, which is pulmonary rheumatology, and they co-manage. But we don't participate into the co-management of pulmonary hypertension at all. That we generally leave it to them. We co-manage the ILD part of this. So that is actually, so that's not anything dramatically different. Interstitial lung disease, methotrexate can be used, and mycophenolate, cyclophosphamide, nintedanib, etc., tocilizumab, and this is the level of evidence A, B, C, etc., etc. So nothing dramatically new here, but worth looking at. What I found interesting was there was no CAR-T in the recommendation as yet. The CAR-T therapy is a big thing. Efficacy of FMT. So let me go back. So I personally find that we have got very, very good treatments, except for gastrointestinal disease. We don't really have anything. My last patient with really bad systemic sclerosis in Portland, she was a lady that I have taken care of for 20 years. She had severe involvement of her intestine and malabsorption, and ultimately we just couldn't treat her, and she went in hospice care. She said that, sorry, but I'm going to die and I don't want any more care. It was heartbreaking for me to take care of her for that long. So to me, gastrointestinal systemic sclerosis is the last frontier that we haven't really found anything which will work on that. So I was very interested in looking at fecal microbiota transplantation. Yeah, right. We don't either, because we use ACE inhibitor. Scleroderma renal crisis is gone with ACE inhibition, and we if there is a whiff of hypertension, we treat them. If there's a little bit of protein, anything above 130/90 blood pressure, I treat them with ACE inhibitor. You cannot. Doesn't prevent exactly, but from 130/90, if it is 135, that hypertension from, so I treat. So I haven't seen scleroderma renal crisis for a long time. Yeah, so you have to be more careful, right? Oh, is that right? Oh, I see. I see. Okay, yeah, yeah. So the people who are in the audience, you didn't hear the thing. So RNA polymerase 3 is a risk factor for pulmonary renal crisis, and Dr. Nalaude was saying that they don't see that here in India, but we see that in the US. But that is not the where we see it. Actually didn't have RNA polymerase 3, but they still had systemic sclerosis and they had renal crisis. So, but fair enough, good point. So I was very interested in this FMT. So nowadays, the people actually do this anaerobic cultivated human intestinal microbiota. So when the fecal transplant is done, it's not really taking somebody else's feces and giving it. They cultivate this in anaerobic fashion. And so this is called ACHIM, ACHIM, anaerobic cultivated human intestinal microbiota. 67 patients randomized to placebo or ACHIM. And it did improve to a small extent. The primary outcome, and of course, this was looking at the fecal incontinence. And UCLA Scleroderma Clinical Trial Consortium, many of you know Dinesh Khanna. And Dinesh Khanna and his boss, Dr. Dan First, developed this UCLA Scleroderma Clinical Trial Consortium scale and Bristol stool form, etc., etc. So the bottom line is it did show some improvement, but not dramatic. So FMT patients had numerically improved fecal soilage scores, reduced diarrhea, but no major improvement in quality of life at week 20. So this was, to me, this was disappointing, but keep an eye out. I mean, I didn't know this. I would have definitely tried this on my patient who actually went for, I was desperate and she decided to die, went for hospice care, which was really, really sad. And most of you got this right as well in your question and answer. This was one of the questions. The world of lupus medication is exploding. There were so many lupus trials there and so many drugs. It is unbelievable what is happening with lupus. I'm going to tell you a little bit about daratumumab, monoclonal antibody for CD38, and obinutuzumab. Obinutuzumab is very similar to rituximab, but it's a glycosylated monoclonal antibody to CD20. So I'm going to show you two of these. So daratumumab is an anti-CD38 monoclonal antibody in systemic lupus, approved for multiple myeloma. It depletes plasma cells. And that worries me. Plasma cells are the ones which actually make your antibodies. So completely getting rid of plasma cells is pretty worrisome. Open label proof of concept study in systemic lupus followed by for 36 weeks. And they took patients who were all anti-double-stranded DNA positive. They had failed immunosuppressive, at least two of them. Their there is baseline SLEDAI 2K score was more than 6. And the dose is 1800 milligrams subcutaneous every 4 weeks for 8 weeks, plus standard of care. All lupus studies have the standard of care. So they probably are getting prednisone, they're getting mycophenolate, they're getting whatever. And on top of that, now they're going to get daratumumab. And the other group will get only standard of care. That's how the studies are done, because you cannot really do ethical studies otherwise. I found this primary endpoint pretty bizarre. Reduction in monoclonal antibodies. I mean, really? I don't care. Patient doesn't care either double-stranded DNA antibody goes down or not. But that's the primary endpoint. And of course, it's going to go down if you kill the plasma cell. So on the top, what you're seeing is this anti-double-stranded DNA, IgG level, and C3 level. And on the bottom, what you're seeing is actually what patient is interested in, like CLASI and this CDAI, the clinical disease activity score, and SLEDAI 2K. So their primary endpoint did meet as shown here. This is the primary endpoint, anti-double-stranded DNA antibody. But then the other clinical parameters important for the patient are also working. Are you guys at home seeing this still and you can hear me? Can somebody say yes?
Yes, sir. Yes.
Yes, sir.
Thank you. Thank you. All right. Yeah. So all the patients achieved an SRI-4 response, 70% maintained it to week 36. There were no serious adverse events. I mean, I'm surprised there were no serious adverse events. My take is that depleting plasma cells to me is a concern for safety. I would like to know what happens to their infections and that get rid of their all antibodies against all the vaccines that we have taken. But daratumumab is going from phase 2 trial to phase 3 trial. I mean, this is actually proof of concept study. So I'm sorry, they're actually now going to start phase 2 trial. This is not even in phase 2 trial as yet. So Richard Fury is a famous researcher in lupus in US. He's a friend of mine, and I was asking him that what is important, because the lupus, there were so many trials and so many things that I just couldn't make up my mind which one are important, which one are not important. So Rich Fury said that you should go and see about obinutuzumab. So I actually found this is background information. This is published. This was published in 2021, 22 or something like that. This was in 22, and also rheumatic diseases. B-cell depletion with obinutuzumab in the treatment of proliferative lupus nephritis, randomized double-blind placebo-controlled trial. Rich Fury is the first author. In lupus nephritis patient, mycophenolate plus corticosteroids and obinutuzumab, 1000 milligram IV 2 weeks apart. So same dose that we would use for rituximab. At baseline 6 months or placebo. Placebo, of course, is only mycophenolate and corticosteroid followed for week 104. Primary endpoint was complete renal response. This I'm telling you for background information. And complete renal response was 35% versus 23%. And in fact, the study failed. It didn't really show to be positive. However, Rich Fury said that no, it's a really fantastic drug, and this is just the problem. The problem with lupus studies has been that they are not able to find good outcome measures, number one. Number two, their placebo also is getting very good treatment anyway. They're getting mycophenolate and cytoxan and steroids. So it's difficult to show improvement on top of that. So Rich was very gung-ho about it. So what they presented at EULAR, so that was the background information. So that study was called Nobility. And this is the post-hoc analysis. And they decided that we are not very good in finding a good outcomes. So we are going to change the outcome. Post-hoc analysis, yes, we published it, negative study. But what if we had used this outcome? So there are other studies called Regency. There is a modifier. So Regency is another study in lupus. They borrowed the outcome that they used in Regency, and they used that outcome in this one, post-hoc analysis. There is a Bliss study, which was on belimumab, for belimumab in lupus nephritis. So they decided to use that. And they used all kinds of this, I call this data torture. If you torture the data, it will confess what you want it to confess. So ultimately, they made the data confess that this drug works. And subgroup analysis. So whichever way you look at it, so this is kind of pretty complicated. But the idea there basically is they use this Regency and then Bliss and the complete renal response basically is that you have to have, and there's slightly different definitions of what complete renal response is. eGFR more than 85% of baseline, urine protein creatinine ratio of less than 0.5 gram per gram, no failure, no treatment failure, no rescue therapy, etc. And that slight changes. The bottom line is that whichever way you slice or dice the data, reduce urinary protein loss, whichever definition you use. And I believe that this drug works. That this is always a problem with lupus studies, and he thinks that this, according to Rich Fury, obinutuzumab is probably the best drug amongst all the current drugs, and I will take his word for that. So better than cytoxan, better than rituximab, better than mycophenolate, better than belimumab, better than whatever you have. So he thinks obinutuzumab is going to be the drug of choice. So this study was for lupus nephritis. Yeah, so the question is whether they have done the study in non-lupus, non-renal lupus. And I'm not aware of that. I don't know. Probably not. Almost always the drug companies will do the studies in lupus nephritis. The other manifestations are difficult. And I mean, the worst one, of course, is CNS lupus, which nobody wants to do that. And lupus involving, so pericarditis, pleurisy responds pretty quickly. It's not that difficult to treat. Arthritis and skin and other kind of lupus manifestations are not that worrisome. To me, apart from lupus nephritis, what is worrisome is CNS lupus or very severe thrombocytopenia. That worries me. The platelet count is 10,000 or 5,000 or something, then that really makes me worried. So this is Gross-Glockner. This is the highest peak. This is a photo that I have taken. This is another picture that I found. And there are these people up here. And they have gone up there on this thing, which is scary. And this guy is going to ski down on that. This is an amazing peak. This is the tallest peak. So vasculitis, we are changing gears. Giant cell arteritis, ANCA-associated arteritis, and Behçet syndrome, that also I'm going to talk about. So what is the shortest course of prednisone you can use in glucocorticoid? So when I was training in England, I was told that for polymyalgia rheumatica, you might be able to get away with 2 years, and for GCA, it takes 3-4 years. Then I moved to US, and they said that, yeah, no, polymyalgia rheumatica, you can treat with prednisone in 1 year. But giant cell arteritis takes 2 years. You cannot really stop it. People are going to get blind. And so we used to treat people with 2 years of glucocorticoids. So now this is a background information for you. This paper is published in the Lancet. Tocilizumab monotherapy after ultra-short glucocorticoid administration in giant cell arteritis, single arm, open label, proof of concept study, GUSTO. Short is 3 days. I cannot believe this. I used to treat with 2 years with prednisone, and now 3 days. I mean, unbelievable. So IV methylprednisolone, 500 milligram for 3 days. And then IV tocilizumab, 8 milligram per kilogram, single infusion, and then tocilizumab subcutaneous, 162 milligram weekly for 52 weeks. And the primary endpoint, and I mean, these people are, I thought it's crazy. I mean, not only they're treating it with just 3 days, but the primary endpoint, they want remission within 1 month for giant cell arteritis. Can you believe it? I mean, we would not even dream of thinking that they're in remission. No relapse at week 24. So interestingly, 1/4 of the patients in this trial, GUSTO trial, went in remission in 1 month only by just 3 days of IV methylprednisolone and 1 IV infusion of tocilizumab and then subcutaneous. Primary endpoint was not met, but 78 had remission within 24 weeks. And so this, in fact, technically was a negative study. 1 person had anterior ischemic optic neuropathy, but then they wanted to follow these people over a long time. So what was presented in EULAR is this GUSTO trial, long-term outcome of people who were treated for 3 days with IV steroids, methylprednisolone, and 1 IV infusion of tocilizumab and then subcutaneous. So they had 15 patients. So what is shown here on the figure are these patients. Blue is there in remission, and red is there in not remission, and yellow is that they are in partial remission. So the median age of these people was 72 years. 2/3 were females. 15 had, out of 18 had cranial, 1/3 had visual symptoms. These were pretty significantly ill patients. 16 were positive for ultrasound. 13 had positive temporal artery biopsy. And at week 52, 13 out of 18 patients were in relapse relapse-free remission, and they even stopped tocilizumab therapy. Amazing. 3 major relapses regained remission. So at week 102, patients were in relapse-free remission. So the conclusion that these people said was that our results of this very small trial are better than any trial that you can see in giant cell arteritis. So they said that this ultra-short glucocorticoid IV and subcutaneous tocilizumab have better remission and relapse rates than any published data. So they were pretty cocky about this. And so this is amazing that how we have made a huge from 5 years treatment of prednisone to 2 years to 1 year to now 3 days. I think it's still very brave. Upadacitinib in giant cell arteritis. And this I thought was very interesting is because there's this worry in the US. And of course, you guys use tofacitinib like candy in India. 9 drugs and everybody gets that. I'm told that in India, orthopedic surgeons, somebody goes to them and they get backache and then they get, is that true? That they get tofacitinib and if it doesn't work, then you go to rheumatologists. Is that what they do? And this is horrendous. Anyhow, and the worry, of course, we have is about MACE events, cardiac events, right? In giant cell arteritis, people are elderly. And so how, to me, this is an important situation as to what is going to happen if you start using JAK inhibitors in really elderly population. So this was a double-blind randomized controlled trial, UPA, and they used this 7.5 milligram dose because of this worry. FDA told them, if you want to do the study, you should use a 7.5 milligram because we're worried about your 15 milligram, knowing that there can be a problem. Gastroenterologists use upadacitinib 45 milligram for Crohn's disease in the US. So new onset giant cell arteritis 70% and relapsing in the remaining. Prior glucocorticoids were more than 40 milligram per day. Current was more than 20 milligram per day. And the primary endpoint was sustained remission. The definition is absence of signs and symptoms from week 12 to week 52. Adherence to protocol, defined taper. And I've shown here basically the primary endpoint was met. Upadacitinib 15 milligram versus placebo, 46% versus 29%. Multiplicity controlled endpoints were met, etc., etc. Again, what is, and these are the Kaplan-Meier survival plots to see what percentage of people stay in withdrawal flare. That's what the y-axis is. And so this top line here are the patients who are on upadacitinib 15 milligram. There's a top line. This is 7.5 and this is placebo. So 7.5 was not better than placebo, but 15 was. But the interesting thing was there were no MACE events. So that's very good. Nobody had major adverse cardiovascular event. That's what MACE is. 2 deaths, 1 COVID, and the deaths, one died of COVID and the other one was unexplained. But I think using these JAK inhibitors in elderly population for GCA will tell us, of course, it's going to work, whether it's going to cause problems or not. Advocate is avacopan. I have not used it that much. I have only handful of patients on this. This is a drug. This is a complement 5A receptor antagonist. I don't know whether you have ever had a chance to use this drug. I mean, it's an expensive drug and it's the only, well, so the original trial, the Advocate trial, just to remind you, was a phase 3 trial in patients with GPA and MPA, granulomatosis, polyangiitis, microscopic polyangiitis, 30 milligram BID. It's a pill, prednisone 60 milligram, tapered to 0 milligram. So the only thing this drug does is it reduces the need for prednisone. You can taper down the prednisone rapidly. And in rheumatology, we are now reducing prednisone as much as we can, as you saw, 3 days, and we are stopping in GCA. So avacopan was non-inferior. That was the original thing. So they looked at the sub-analysis. They're trying to find, the company is trying to find a niche for this drug somewhere. Please use my drug somewhere, kind of thing. And this is the ENT part, the ENT involvement, the upper part involvement in GPA and the sinuses and sinusitis and ears and retroorbital disease, etc., etc. And what they found out was that avacopan showed faster resolution of ENT manifestation and similar safety versus prednisone. So I'm still not 100% convinced that this drug is of great use, but it is in difficult cases to add this drug to get some thing. This was an interesting thing. Infliximab versus cyclophosphamide for severe Behçet syndrome. several interesting things. Number one, if any drug goes head to head with cyclophosphamide, I mean, I get great respect for that drug. The cyclophosphamide, oh my God, you are going to compare your drug with cyclophosphamide. And so they did. Number two, severe Behçet syndrome. Most of the time, the studies are done on drugs, on disease. So there are lupus studies. Nobody wants to do a study with CNS lupus. Nobody wants to do a study in the lung problem with somebody having severe pulmonary hemorrhage. People are worried about doing studies on people who are severely ill. Here, they chose to do a study on CNS Behçet syndrome and vascular Behçet syndrome. And they just wanted to do this very small study. They are called Bayesian randomized control trial. In Bayesian studies, they use very small number of patients, but you can still do, and there are some statistical maneuvering that you can do to show the difference. And this is called posterior probability. And don't ask me exactly how that works, but the posterior probability is somehow you get these two graphs. And if those two graphs are separate and they don't overlap, then the drugs are separate. And then the drugs are, one is better than the other. And there is a very small tail here, which is kind of one on top of the other. So vascular changes, so vascular complete response, 94% for infliximab compared to cyclophosphamide, 56%. Neuro Behçet syndrome, complete response, infliximab 71% versus cyclophosphamide 57%. One relapse. So interestingly, infliximab was better compared to cyclophosphamide for severe Behçet syndrome. So for severe, its complete remission rate was better and the safety was compared to cyclophosphamide. So I thought this was pretty interesting. Changing the gears, Hellingblut M. Grossglockner. M means on. Hellingblut is the name of this town. Hellingblut M. Grossglockner means Hellingblut on Grossglockner. So this is a small village. So people told us that, so when we were there, that you should go and see, this is a very pretty village. It really is extraordinarily pretty. But then that is, you have to leave the that thing and you have to come back in again. So we actually asked our hotel person that, do we have to pay that 44 euros again? They said, no, it's part of this national park. So we go there, we have a good time, and coming back, again, we are stopped and they say 44 euros more. No, we were told not to, euro is more expensive than dollar. So this is kind of like $50. Anyhow, but there are these very, very pretty villages, and this is a nice church there. Axial spondyloarthritis and psoriatic arthritis. This is a background information about the TICOSPA trial. This is the only tight control of spondyloarthritis. Efficacy of tight control and treat to target versus open label pragmatic cluster randomized trial, TICOSPA. And this is the only tight control study, 160 patients randomized. This is old information published in 2021. The patients with ankylosing axial spondyloarthritis were seen every 3 months. And the regular control, they were asked to do whenever you can see. And the primary outcome was ASAS health index. And it has to be more than 30%. And it was 47%, but 36%. The P was not significant. It came close, but it failed. So tight control was not superior despite twice proportion of patients getting biologic DMARDs. People who firmly believe in treat to target, they said, no, of course it works. We actually chose probably a wrong outcome measure, ASAS health index. We probably should have chosen ASAS 40. But then they couldn't use ASAS 40 because the tight control people were seeing the patient, and if you're not 40% improvement, you're going to increase your dose. So it becomes a circular argument. So you cannot really use the same thing as your outcome measure, and the same thing you cannot use in misleading, whether if you're not getting it, then I'm going to increase your treatment. So this is EULAR. Escalate is the name, new treatment, a new standard of care versus secukinumab. Treat to target in patients with axial spondyloarthritis. Open label, treat to target randomized care. So the standard of care was investigator discretion. Here's your patient with axial spondyloarthritis, treat the way you want it. The other group was treated first with regular dose, loading dose of secukinumab. You guys use secukinumab, right? Or not much? Yeah. So baseline week 1, week 2, week 3, week 4, 150 milligram, and then 150 milligram every 4 weeks. And if that did not bring, so they use actually SS40 response, and they were looking at their outcome measure actually. So that's the primary endpoint, but they use ASDAS, clinically important improvement. So you start the patient on this, bring the patient back, and they don't have ASDAS clinically important improvement, then they will go to 300 milligram of secukinumab. Bring the patient back, still no ASDAS clinically important improvement. Okay, I'm going to change it to adalimumab. So first secukinumab, then double dose secukinumab, and then adalimumab. That's all how the treat to target worked. And the primary endpoint was not met again, 40% to 49%. In fact, the people who were treated standard of care did better, which is kind of a really sad situation. So this is the second drug, or rather the second trial, where it was clearly shown treat to target is not superior over standard of care. If you look at ACR guidelines, which we are now developing again, and if you look at the EULAR guidelines, EULAR is very much for treat to target. ACR is saying that treat to target is not yet ready. A. B, it is very expensive. C, it is too much cumbersome for you to see the patient that often. And patient may not really want it. And you're going to, what exactly are you going to try to avoid? Are you trying to prevent them to get bamboo spine? And the chances of that are very, very, very small. Once you put them on a biologic, their MSAS increase becomes so minuscule nowadays. And actually, I might actually have a, okay, here it is. This is bimekizumab. The spinal radiographic progression has become a thing of the past, is what I believe. So this is spinal radiographic progression in radiographic expertise with bimekizumab, which is a IL-17A, IL-17F inhibitor, subcutaneous, not yet approved in the US. They are already approved in Europe. They're hoping to have it approved by the time of the ACR. So at Washington, DC, they want to do a big splash. So if you go there, there's going to be a big booth by UCB. That's what they're dreaming, that it will be approved. B-Mobile 2, B-Mobile 1 was the non-radiographic study. B-Mobile 2 was a radiographic study, phase 3 study. And after 52 weeks, patients enrolled into open label, 160 milligram every month subcutaneous is the dose. All right, and this is what it shows. And these are the people. So actually, nearly 90% of the people have no progression. And the average progression was 0.3 MSAS. It is minuscule. In the olden days, when we did not have biologics, it would go up by 1 or 2 in 1 year, 2 years span. With anti-TNF, it came to less than 1. Now it is 0.3. I mean, this is, patient won't really feel anything. So treat to target for what? I mean, it's not treat to target, but I'm going back to my original idea why the US ACR and Spartan not very fond of treat to target in XLSTA is what really are you going to achieve by treat to target? So this is very, very small progression. So minimal spinal radiographic progression at bimekizumab. So what's a nanobody and how does it differ from antibody? You guys probably know this. And the reason I'm showing this is these are cameloids. So to me, the real thing is what's the difference between an alpaca and llama? So that's why I'm showing you. This is llama. Alpaca is more cute than llama. Llama kind of looks more like a donkey or a horse or something. And they're also cute. This one is cuter, as far as I'm concerned. Anyhow, cameloids actually have nanobodies that we don't have. And the nanobody is this, this variable region of the heavy chain, VHH, the variable region of the heavy chain, the very top part. And they have this in their normal circulation. It's a single domain antibody derived from the variable region, and they are molecular weight of only 11 to 15 kilodalton, very small. They're highly stable, highly soluble, hydrophilic. It has deep tissue penetration. So diseases like hidradenitis suppurativa, which is with all the scars and this and that, and we generally send them for surgery and etc. This is an amazing, so blocking IL-17A, IL-17F with nanobody is going to make, that's what the company says, is going to change. And they've done the study for hidradenitis, it's going to look dramatically good. So nanobody is different than monoclonal antibody, but it's an antibody to start with. Argo is the study. Sonelokimab is, we are doing this study in PSA currently at OHSU. It's a 40 kilodalton humanized. So one of the problems with this small nanobody is it gets excreted through the kidney. So they attach it to the albumin. So this sonelokimab, it blocks IL-17A and IL-17F, and it is blocked to attached to albumin, but even then it doesn't become too big. That's why it is 40 kilodalton, not 11 and 15. So it reduces renal excretion, but it does have good tissue penetration. And this is psoriatic arthritis study, phase 2 study. Sonelokimab 60 milligram every 4 weeks with induction, etc., etc. It works very nicely. ACR 50 response rate. They actually added adalimumab as well as a control. So there is a placebo control and there is an active control. So the active control is adalimumab, and the drug works very nicely. ACR 50 responses are very, very good. And I'm very aware of the time, so I'm going to move a little bit fast. So this is their primary endpoint, ACR 50 responses, and this drug works. Well tolerated, no IBD. I mean, blocking IL-17A and F, you worry about IBD, you worry about candidiasis, so mild to moderate cases. So this drug is already going into phase 3 trials. They already have done a small proof of concept trial in axial spondyloarthritis. And so this will come in that. And hidradenitis suppurativa nanobodies are going to be very useful. All right, some background information about, can you prevent psoriatic arthritis by treating psoriasis patients with biologics? That's the question. So incident psoriatic arthritis, new psoriatic arthritis, can you prevent it if you treat psoriasis patient with biologics? And this was a study. So this TriNetX, this is an amazing database. So there are, TriNetX is a database where, so we have electronic medical record in the US. They have somehow, there are many universities participate in this. So rather than insurance claims database that every patient in the US, when they get a drug, their name goes into insurance claims database, but that doesn't have disease activity, that doesn't have any information about their CBC or their liver function test, etc. TriNetX is actually a database of the electronic medical records of millions of patients. They are de-identified. So you really get a huge number of patients. So this study was published in last year. And the bottom line is, so they said that patients with psoriasis treated with anti-TNF, we are going to compare them with patients with psoriasis treated with IL-17 inhibitor, patient with psoriasis treated with IL-23 inhibitor, patient with psoriasis treated with IL-12/23 inhibitor. And we are going to follow them, and this is a retrospective analysis, not follow them, but this is looking into patients' claims. This is their medical records. And what they found out was patients who were treated with IL-12/23 inhibitor or IL-23 inhibitor had less development of psoriatic arthritis compared to patients who were on TNF inhibitors. And IL-17 inhibitor and TNF inhibitor, there's no placebo here because these people have psoriasis and they're being treated. But compared to that, blocking 23 somehow is better. So this was from the US, TriNetX. Now, what was presented at EULAR is this TriNetX database worldwide, 213 million patient database. Can you believe it? This is big data. Big data coming in now. Artificial intelligence and big data. This is an example of big data. 213 million patients database. In that, they found 1.1 million patients with psoriasis and 928 patients. Out of them, 928,000 patients were without psoriatic arthritis. This is ex-US, outside of US, TriNetX. And they had this electronic medical record history from 2010 to 2023. This is really how new research is happening, big data. Treatment received were TNF inhibitors, IL-12/23 inhibitors, IL-17 inhibitor, 23 inhibitor. Propensity score match for sex, time since psoriasis diagnosis. And I mean, here again, everything is depending on who is, this TriNetX is just looking at insurance, not insurance claims, your electronic medical record. So you depend upon wherever it's coming from, hoping that they had good data. So that's the one of the drawbacks. You don't know how good the data is because rubbish inside is rubbish outside. So, but this should be pretty good. Anyway, the bottom line is they found exactly the same thing, IL-12/23 inhibitor and IL-23 inhibition treatment for psoriasis reduces psoriatic arthritis incidence compared to TNF and IL-17. And we can discuss this later if you have time about, and I think there is a biological plausibility why that is the case. But I need to move quickly. Comparative safety of JAK inhibitors. So now again, another thing, TriNet X. So does really do JAK inhibitors increase risk of myocardial infarction and etc. And you can look at this same database of 129 million patient database. And they looked at patients who were, this is US electronic medical record, incident cardiovascular disease, VTE, cancers, etc. And they compared JAK inhibitor to TNF inhibitor. So this top part of this table that you can't really read is JAK inhibitor compared to TNF inhibitor. Bottom part is JAK inhibitor compared to IL-17 inhibitor. And you can take my word for that, that basically there was no increased risk of cardiovascular disease and venous thromboembolic things or cancers. So at least in this large database, global cooperative network, mostly from US electronic medical record database, they found out there was no increased risk. So this is a chairlift. And of course, there is snow here during winter. But when we went there, so it's kind of like meadows, alpine meadows with beautiful flowers. So this is Zell MC. So M is on, as you know how. Zell on sea. So this is the town on sea, is this lake actually. Sea is not ocean. And it's a beautiful place. And we stayed there and we hiked on this slopes. It's another beautiful view from alpine meadows. Rheumatoid arthritis. I'm coming to the end of my talk soon. You'll be happy to know. So differences. So these are all, this is about rheumatoid factor. And should we be considering whether rheumatoid factor positivity, of course, negativity, we know that, but level of rheumatoid factor, does that then make you decide about which treatment you're going to use? And the reason I show this is, so here is a rheumatoid factor, and the rheumatoid factor actually binds to, there is an IgM rheumatoid factor binding to the IgG, and this could be a monoclonal antibody, one of our drugs. This could be anti-TNF, right? So this anti-TNF antibody is binding to TNF, but then that binds to the rheumatoid factor. So certolizumab pegol is the only one which does not have this FC receptor, because this IgM RF rheumatoid factor is binding to this FC portion of the monoclonal antibody. So it forms an immune complex and then it destroys it. So the point is, if you have got very high levels of rheumatoid factor, then the anti-TNF or other monoclonal antibodies, which is got an FC portion, is going to be blocked by this rheumatoid factor. And so median drug concentrations, it's all background information. So these are seronegative. So this is blood levels of adalimumab in patients who are seronegative. Of course, they don't have rheumatoid factor, so their levels are high. And then this is mild or low, moderate, and high levels. So when the high levels of rheumatoid factor, and I forget what the definition of high level is, but there is a decrement, there is a reduction, whereas for certolizumab, it doesn't differ, right? So what was shown in EULAR was the same thing, and I had never thought about this, and so I thought this was an interesting particular abstract. And they actually, you can buy commercial rheumatoid factor, and there are three types of commercially available IgM rheumatoid factors to TNF inhibitors, and so adalimumab was bound by all three rheumatoid factors. There was no binding of certolizumab, and so they said that rheumatoid factor IgM binds to the FC containing adalimumab but doesn't interact with the certolizumab. So this was interesting to me. Rheumatoid factor levels might help in choosing the biologic, and in fact, this trial is already published in the Lancet many years ago called Accelerate, and this was a trial head-to-head study of adalimumab versus certolizumab. And in fact, they found no difference between adalimumab versus certolizumab head-to-head trial in rheumatoid arthritis. But then when they looked at high titer and low titer, then in fact, what they found out was with certolizumab, the patients treated with certolizumab, and those actually, this is according to quartile, first quartile, second quartile, third quartile, and those who are third and fourth quartile of rheumatoid factor, then adalimumab, then patients with the high count, there was a difference between certolizumab and adalimumab. In other words, patients with very high levels of rheumatoid factor treated with adalimumab have less response compared to those treated with certolizumab. So I thought that was interesting. Now we have completed our tour and we are back in Vienna. This is the Vienna Opera House. CAR T therapy. And very quickly, systemic sclerosis, I thought is not reversible. And so CAR T therapy in systemic sclerosis, single trial experience. And this is coming in a big way. We are starting 3 trials in OHSU on CAR T therapy in systemic lupus, systemic sclerosis, and actually 4, myositis, and also ANCA-associated vasculitis. 1 year follow-up on patients with severe diffuse systemic sclerosis, immunosuppression stopped after 4 weeks, and they looked at various different outcomes. And the results are that this really works. So there is no remission, but there is stabilization. And I won't go into the details, but they looked at this modified Rodnan score at 3 to 4 months, at 12 months, Raynaud's phenomenon, digital ulcers, ANA titers, all these anti-RNP3 monoclonal antibodies, pulmonary function stabilize, and then they actually did some biopsies as well. So it's a great new thing that is coming in, and we might be able to treat our patients very well. This is the museum. Actually, no, this in fact is this is the old Habsburg Palace converted to a museum. And this is one of the Habsburg crown mukut. So this is one of my last trial, last one actually. This is the last one. How to optimize referral for inflammatory disease. This is not important for people in India because we, in fact, have a waiting list. I got a waiting list of 4 months, which is incredible. Somebody wants to see Dr. Deodhar. September, come back in January. I mean, crazy. This doesn't happen in India. So our system is broken. And so we don't want to see patients with osteoarthritis. We don't want to see patients with Ehlers-Danlos syndrome. We don't want to see patients with fibromyalgia. So how can you increase referrals of only inflammatory disease and not see the other people that we really can't do anything about it? So something similar is happening in Germany. And what they did was they used 2 things. One is CRP and something called this FIRST, FIRST. This is fibromyalgia rapid screening tool. For every patient referred to your rheumatology division, do your CRP and do your FIRST. And then based on that, you decide whether you take the patient or not take the patient, what are the chances. So this is what they did in Germany because there also they have got this long waiting list. And I won't go into the details. This is my very last slide anyway, and we are coming to the end of it. But if all patients with inflammatory rheumatic disease had either CRP more than 5 and or the FIRST was less than 5 score on that. If that is the case, then you should accept the patient. If it's not, then you maybe I should see somebody else. Except 94 patients, and those 94 patients, they had some other things and how they missed it. But the bottom line is that 2.5% of all inflammatory rheumatic diseases can be missed by this particular strategy. All right. So now you do know the answers to these questions. I'm coming to the end of it. What is the mode of action of nipocalimab? And nipocalimab is this the neonatal FC receptor inhibitor. Drug of choice in severe vascular CNS Behçet syndrome is infliximab. How good or bad is a reproducible salivary gland biopsy, which is very good. Nothing much new in the EULAR recommendation for systemic sclerosis, apart from new things for pulmonary hypertension. You can tell your pulmonologist to read them. Daratumumab is anti-CD38 monoclonal antibody, which kills the plasma cells. Shortest glucocorticoid course is 3 days. Unbelievable. Difference between nanobody and antibody, you know that part. Which biologics are touted to prevent incident PSA? Any drug which has got IL-23, 12-23, or just 10-23. Should levels of rheumatoid factor impact? And maybe it should. And how can we optimize referral? So this is my last slide. 2005. I think I'm getting younger. This is the same place. This was EULAR 2005, and I had done this talk for Arthritis Foundation in Portland. All right. Thank you so much. This is for Arthritis Foundation. Questions? Anybody has a question? Oh, there were so many things on excipients. There were, I mean, as I said, I got 20 abstracts. There were many things. Is there any specific question you have about excipients in Yeah, so the question is ixekizumab really better for axial spondyloarthritis? So ixekizumab is IL-17A inhibitor, and in my experience, it is slightly better than secukinumab. If patients, secukinumab is a very good drug, but patients who have failed secukinumab have responded to ixekizumab. I don't have any patient who has failed ixekizumab who has responded to secukinumab. So maybe tiny bit better, but nothing dramatically different. In the US, we are forced by what the insurance company tells us to use because one drug is approvable, other is not approved, etc. But there were studies on ixekizumab, and which one is there? Anything that stood out for me? I don't know. So, but yes, it is very good drug for XLSPA, psoriatic arthritis.
Versus anti-TNF in XLSPA.
Yeah. So secukinumab versus anti-TNF, there is this big study called SURPASS. I don't know whether we discussed that. SURPASS was a head-to-head study of secukinumab versus adalimumab biosimilar. And I mean, I think it's an amazing, I'm actually speaking on that in 1 week in Brazil, in fact. The company, I mean, companies worry about doing these head-to-head studies because they think that they might be shooting themselves in the foot if their drug comes inferior. These people were cocky, the Novartis people, and not only they called it SURPASS because they want to show that their drug is even better than adalimumab, superior, and that is in the newborn formation. So their primary endpoint was superiority of to show the superiority in MSAS reduction and number of patients with zero progression. The bottom line is after 2 years, both were identical. So the study failed, but it showed that IL-17 inhibition also reduces, and there's no placebo. So I cannot really say it reduces radiographic progression because compared to what? Because there are no placebos for 2 years compared to historical control. But to answer to your question, in my mind, secukinumab is as good as anti-TNF when it comes to radiographic progression. Their clinical data also looks very similar, so there isn't really anything better. So negative studies sometimes tell us good things, and this was one good thing that anti-TNF work. And on the skin, so my experience is that secukinumab is as good as anti-TNF for spine, as good as anti-TNF for joints, etc. For skin, it is better. For eyes, it's not as good. For uveitis, for IBD, it's contraindicated.
Take it. I just.
Yeah. I don't think this is working. Hello?
The patient has spondyloarthropathy,
Yeah.
uveitis,
Yeah.
and does not respond to anti-TNFs.
Yeah.
So then what would you do?
Yeah, so then it depends on, can you hear me in this? I mean, you guys can hear me. I don't know whether these people there are hearing me or not. So it depends on primary non-response and secondary non-response. But for primary non-response, then we would move to IL-17 inhibitors or even JAK inhibitors. Secondary non-response, I would stay in the same course. I would like to change the, I mean, I can even increase the dose if I can. Adalimumab, we can try giving it once every week. Infliximab, I can make it every 4 weeks and all this kind of stuff. So usually that's how we will do. For psoriatic arthritis, now they actually have this combination trial of IL-23 inhibition and TNF inhibition. That trial, double biologics, yeah. And that trial has been completed, but it's for psoriatic arthritis. I don't think this is working, which is, no, that's okay. I mean, I don't know whether these people are able to hear me or not. Yeah. So for psoriatic arthritis, there is a TNF inhibition, IL-23 inhibition, combination biologics trial. And that is not been done in XLSPA, but that is something we will go. But IL-23 inhibition doesn't work in XLSPA, so that won't be a good trial. Then we recently wrote a review article on combination biologics. I had 2 medical residents, internal medicine residents, both wanted to go into rheumatology. So it's published, and we did a literature review as what is done. And there are studies which show that combination of IL-23 inhibitor drugs like use tequinomab, 23 inhibition or 23 inhibition with either IL-17 or TNF. It's pretty safe. If you think about it, JAK inhibition is, what is JAK inhibition? I mean, that is biologics, multiple cytokine inhibition. What is methotrexate? Multiple, I mean, God knows, what is prednisone? We use 500 milligram IV bolus of prednisone. What kind of cytokines are we blocking with prednisone? So we already are blocking multiple cytokines with methotrexate and cyclophosphamide and all these things. So, but when it comes to blocking two cytokines, we start worrying about it. Of course it will, but then what are you doing when you're using without thinking, giving somebody 80 milligram of prednisone? You're blocking many things. So, yes. Preferred what? Oh, dactylitis. Dactylitis in ankylosing spondylitis and axial spondyloarthritis is very rare. That's number one. 2% or less. Dactylitis is common in psoriatic, well, not common, but in axial SPA, it is pretty rare. We did this big study, recently completed a classic study, and dactylitis was very, very rare, 2%. That's where this number comes from. But the drug of choice would be, so IL-17 inhibition might be better. I mean, many times dactylitis becomes chronic and it may not hurt. It looks terrible. It may not hurt, but it remains permanently swollen. I've done steroid injections as well, local in the MTP joint or MCP joint, whichever. And another one in the PIP, trying to reduce the inflammation. But there I would probably prefer IL-17 inhibitor drug compared to TNF inhibitor from my experience. But I don't have anything to prove for that. So the question is, do we have to use two anti-TNF before using another drug? It totally depends upon every insurance company. Some insurance companies will allow us to use IL-17 even before using anti-TNF, and now AbbVie, which their drug is upadacitinib, Rinvoq. In some places, we can use Rinvoq before anything else, which is, of course, not FDA. FDA want us to use TNF inhibition before using things. But in Europe, certainly, they don't have that restriction. Yeah. What percentage of my patients would be on only NSAIDs without anything? And we looked at that, and I got data on that. In the US, I can tell you, because in the axial SPA, 67% of people with axial SPA in the US are on the biologic or a JAK inhibitor, so some advanced therapies, which means 33% of the people are not receiving. These are axial SPA people. This is insurance claims database. And I probably would say in my practice about 20% would be only on non-steroids. Yes. 80% would be on some biologic. Yeah. So the question is, the early spot definition by ASAS is less than 2 years. And should we be treating them early? So, yeah, so the reason why we are treating patients in axial SPA is to improve their quality of life, not for newborn formation. So by using non-steroidals alone for 3 months, they get no relief. Of course, I will treat them. If they get relief, then nothing. Then the 2 years, 4 years doesn't make any difference. But within 3 months after starting non-steroidal anti-inflammatory drug, if the patient is not getting relief, then irrespective of their this is early disease or mid disease or late disease or whatever, I'm going to go up to starting them another well, I would probably try a non-steroidal for 4 weeks. If that doesn't work, another one for 4 weeks, and within 2 months, nothing is happening. I will move to a biology. And it doesn't matter whether they're early or late or what. So
data on continuous versus on-demand biologics like anti-TNF?
That should come from India. So the question is continuous versus on demand, and you don't do any of that. And that is done in the India, right? Yeah. Yep. That study has not been done. That's a great chance for you to do that study. And the intermittent and continuous, that was only on celecoxib, that study that you mentioned. There it showed, and they were looking, in fact, at radiographic progression, which nobody was able to actually replicate that study. Diclofenac, correct, and that failed. So the diclofenac study failed to show that diclofenac reduces radiographic progression. This one actually showed that the intermittent use, so the continuous use was better than intermittent use, which was very surprising. Because if you look at the mean amount of the celecoxib that they received in that study, both the groups, was very similar. So there may be something with COX-2 inhibitors, but the study that you're mentioning definitely should come from India, and it has not been done about intermittent use versus regular use, because we worry about antibody production, and then it may not work again, and then the insurance company may not pay us, etc., etc. So once we start them, we are not going to use them in intermittent. We taper it down, but we don't completely stop ever for XLSP. Yes, with sepigrumab, have in secondary failure a lot. Yes, absolutely. Yes, you can use them. Yes, yep, absolutely. Thank you. Thanks for coming and engaging with me.
Thank you very much. As usual, an academic feast in the middle of Ganesh festival. Thank you for all of you who have gathered for in this festive season. Whether sir, we are always elated to host you for these kinds of talks. Thank you very much for inviting us. This was a mini tour to Vienna and mini EULAR highlight for us. Thank you very much. I would like to thank online audience also. There was more than 40 online audience for this talk. So thank you very much. And I would like to thank sponsors also for helping us to organize this meeting.
Yeah, very good evening to all, sir, and all respected. Pharmaceuticals, we have all rheumatology baskets, and this is a great CME, sir, and it's interacted the all new technology is from international markets from Indian market. So this is a great learning, sir, with us also. So it's our pleasure to come and discuss with the in front of the rheumatology. Thank you so much, sir.
Thank you. Thank you. Thank you for sponsoring this. All right. Thank you, everybody here. Thank you for the people online. We are going to close the meeting.
Thank you, sir.
Thank you.
Thank you, sir.
You want? Or leave the meeting? Yeah.